University of Michigan. For those of you joining as participants, this is our first virtual Wolverine Caucus for 2021, but the caucus itself has been in existence for over 20 years, providing a forum for Lansing University of Michigan alumni, as well as legislators, lobbyists, staff, and advisors working in and around the state capitol in mid-Michigan. Traditionally, the Wolverine Caucus hosts a luncheon in Lansing, and the programs feature U of M experts on timely, relevant public policy issues during the legislative session. Our mission is to provide diverse forums at which U of M friends can meet one another, enjoy fellowship, exchange views, and hear from U of M faculty and administrators. Before I introduce our panel, I'd like to run through some quick housekeeping items. First, this webinar is being recorded. If you do have questions for any of the panelists, please use the Q&A feature to ask your question. You do not need to digitally raise your hand. The Q&A feature will be monitored by myself, and we will continue the Q&A, or excuse me, we will conduct the Q&A following the presentations. Reminder that this is a webinar. Attendees cannot see each other. Attendees can only see the panelists. And as panelists, we cannot see you. I believe we have nearly 100 people on the call, so unfortunately we may not get to all of your questions, but we'll do our best to try. So with that said, I want to introduce our very first presenter, Dr. Preethi Malani. Dr. Malani is the Chief Health Officer here at U of M and also serves as the Director of the National Poll on Healthy Aging. As our Chief Health Officer, Dr. Malani serves as an advisor to President Schlissel on matters of health and wellness of the university community, including disease management, public health preparedness, and promotion of healthy practices. And that is on all 3 campuses. For the purpose of this conversation, Dr. Malani has recently embarked on a critical initiative in launching the National Poll on Healthy Aging, which is based at the Institute for Health Policy and Innovation. Through her leadership, the poll has conducted 35 polls in partnership with AARP Michigan Medicine. The National Poll on Healthy Aging is a nationally representative survey which aims to inform the public, healthcare providers, policymakers, and advocates on issues related to health, healthcare, and health policy. Our second presenter is Dr. Lindsay Kobashi. Lindsay is an assistant professor of epidemiology and is the principal investigator for the COVID-19 COPI study, which is what she will discuss today. Lindsay studies the social epidemiology of cognitive aging and health equity among low-income and older populations. Finally, rounding off our panel is Dr. Jason Makayeski, and I totally botched that, Jason, I apologize, is the Chief Advocacy and Planning Officer for Senior Alliance, the 1C location for the Michigan Area Agency on Aging. Jason is a tireless advocate for resources such as Meals on Wheels and direct program operations that impact the lives of older adults. He is a graduate of the University of Michigan Dearborn and holds a bachelor's in political science and master's degree in public administration. So with those introductions, I will quickly turn over to Dr. Malani for her presentation. Dr. Malani.
Thank you, Rebecca, and thank you to everyone. I'll take my slides now. I'm truly honored and delighted to be here to represent both the university and the Institute for Healthcare Policy and Innovation to share an update from the National Poll on Healthy Aging. And just as an aside, I really feel fortunate to be here. I was born and raised in this great state, and I'm so just grateful to be part of this conversation, and I'm glad that we're having this. Also, as an infectious disease doctor in the midst of a pandemic, I'm excited to talk about something other than testing and vaccines. I often say that COVID is not the only risk to our health, and that infection is not the only risk to COVID. And I think this is illustrated very well with older adults. If I could get the next slide, please. Now, Americans are living and working longer than ever, and being healthy in every sense of the word is important to older adults and their family, physically, socially, financially. And this is important for us from a health policy perspective because it's a large and growing segment of the population. And this group consumes a disproportionate amount of health and healthcare expenditures. And you can see here that in the past 100 years, Americans are living 3 decades longer than they were. So that's a relatively short amount of time to get to average age of 79. And we'll see where this number goes since COVID has affected longevity a bit. If I could get the next slide. It's also important to consider that in coming years, this population, this 50 and above population, is going to grow at a higher rate than younger adults. So this will continue to be a really key area of focus. So back to a little bit about the poll. If I could get the next slide, please. Oh, and I'm sorry, just one more comment about our state. And these data are from 2010, and we're all waiting on the 2020 census data. But Michigan as a whole, as a state, is a little bit older than average. And the expectation is in the coming years, we'll have more older adults than children in the state. So again, these numbers are a little bit out of date, but I present them as a little bit background. If I could get the next slide, please. So we often talk about wanting to understand what everyday people think. They're sort of getting at the gaps in our knowledge that you can't get at with traditional research methods. And the National Poll on Healthy Aging really grew out of a desire to understand and fill in some of those gaps on a number of issues related to the day-to-day lives of adults in the US, particularly the experience of older adults and their families. And for the purposes of this poll, we're interested in US adults aged 50 to 80. So not just aging, but pre-aging. And what we do with the National Poll on Healthy Aging, it's a recurring nationally representative household survey on US adults on all kinds of topics related to health, healthcare, health policy, things that affect older adults and those around them. And I want to make a point of saying we use the term health very broadly. Our goal is to move beyond traditional medical issues and really get at various aspects of social and overall well-being. And I'm really, really proud of our team. And it's been such a team effort. Since 2017, when the poll was launched, we've had, I almost like lose count, but I think it's 33 reports to date. And I'll share a link in the chat later for anyone who wants to check it out. And number 34 is coming out next week. As the pandemic began to unfold, it really became clear that this wasn't going to be a short-term thing. And the poll team wanted to take a moment and really capture some of the day-to-day effects of the pandemic on our study population. We tend to talk a lot about deaths and hospitalizations, but we don't really talk about all the other ill effects on health. And if I could have the next slide, I'm going to share one of the reports. This is on loneliness and social isolation. We also looked at things like telehealth and vaccines, and just this idea of all the things, every aspect of your life has been touched by the pandemic. And again, I encourage you to visit our website, which is healthyagingpoll.org. So in June of 2020, we asked a national sample of 50 to 80-year-olds about a lack of companionship and isolation, this idea of loneliness, social interactions, and other health behaviors. And this was actually a follow-up study to a similar poll that was done by the National Poll on Healthy Aging in October of 2018. And it was a comparable national sample, not exactly the same sample. And if I could get the next slide, these are some of the key results here. And the comparisons shown here from 2018 to 2020, really in the midst of the, from March to June of 2020, which was, as everyone remembers, sort of the key time when people were asked to stay at home and really limit their interactions. This shows, not surprisingly, a substantial increase in loneliness and isolation among older adults from before the pandemic to the pandemic. And in particularly, 41% noted a lack of companionship, and this was up from 34%. And we use that as a measure of loneliness, a lack of companionship. 56% said they sometimes or often felt isolated from others. And this was more than double the 27% who felt this way in 2018. And of course, we asked people to become isolated in a way because of the public health mitigation. And social contact suffered as well. 46% of older adults reported that they infrequently interacted with friends, neighbors, and family outside their household, and doing so once a week or less. And this was compared to 28% who said this in 2018. So if I could get the next slide. We also asked about things people were doing to try and provide social connection, social interaction. And technology was really prominent, and many people 50 and above were connecting with others including 59% who are using social media at least once a week, and 31% who used video chat at least once a week. And I know this has been something that within my family has become had become sort of a weekly thing. And again, technology is not equal in terms of access and equity, but this was something that we saw. And 46% of older adults said that they interacted with people in their neighborhood at least once a week. And it's hard to know whether that number is higher or lower than usual, because again, in some cases, people were going out of their way to take a walk and interact. But one of the things we noted is that the people who said they did these things were less likely to say they'd experienced forms of loneliness. And again, we don't have a way of knowing whether doing these things prevented loneliness or not being lonely helped do these things. And I'll just say that intersection of loneliness and health, it really needs more to study. And there's a lot of suggestion that loneliness is very, very bad for your health. People talk about it as equivalent to smoking even. And while we sort of figure those things out, I think all of us can take time to reach out to our neighbors, our friends, our relatives, particularly those who are older, and just really coming up with safe ways to interact. And I will just say, just for a moment, I know we're talking about older adults, but the issues of loneliness really span the whole age spectrum. And frankly, I worry about this issue in our college students too, in my role as chief health officer. And part of what I talk about every week is focusing on what we can do instead of what we can't do. And I just want to end by saying, that use of technology can bridge some of the gap, but it is important, to really think about other things, less technical things like going for a walk, getting enough sleep, eating well. And I think all of this really gets at the fact that the pandemic really gets at all aspects of well-being, not just infection, not just hospitalizations and death. And with that, I'm just going to move on to the next slide. And this is just some information for you, for anyone who's interested in and thank you for Rebecca for sharing that in the chat. This is some information. We'd love for you to sign up for our alerts. We have our next report is coming out next week. And my final slide, for those, everyone from Michigan knows, our famous legendary coach, Bo Schembechler, talked about the team. And I just wanted to acknowledge my team, who is, they actually are now living in boxes on my computer. We're not meeting in person, just like everything else, but they live right here in my heart. They've been phenomenal. And I want to particularly call out Dr. Erica Solway, Dr. Jeff Colgren, who are the associate directors of the poll, as well as Matthias Kurt and Diane Singer, as well as everyone else at IHPI who helps keep the trains going. And I want to also acknowledge our partners at AARP and Michigan Medicine who sponsor the work as well. And with that, I'm going to hand it over to Lindsay.
Thank you for that inspiring talk, Preeti. I'll just share my slides here. And I'm assuming everyone, oh, hang on. Technical difficulties, give me a moment. Okay. Everyone can see this? Okay.
Yeah.
So I think this is a really nice follow-on to the presentation that you just gave, Preeti, and I'm going to present results from the COVID-19 coping study, which is a longitudinal cohort of just under 7,000 adults aged 55 and over across the United States. And we tracked loneliness as well as other well-being, social, health, and economic factors over time. So I'm going to show you some of this. Is actually really exciting because this is some of the first emerging data on time trends over the first 6 months of the pandemic. When I talk about the pandemic, when I give presentations like this, I talk about the COVID-19 pandemic as being like an onion. I think this is very much in line with what you just heard from Preeti Malani. And what we see on the outer layer of the onion on the surface are, the direct infections due to COVID-19 and mortality. But once we peel back away from it, we see a lot of secondary health and well-being effects, primarily mental health and loneliness. There are also huge economic effects, secondary mortality and things like that. And what the COVID-19 coping study aims to do is get at some of these secondary effects on health and well-being that are happening during the pandemic. So we're aiming to track dynamic changes in older adults' experiences, perspectives, coping strategies, and mental health during the pandemic. And ultimately, what we want to do is identify risk and resilience factors that influence mental health during the COVID-19 pandemic that ultimately can be used to inform interventions to support mental health. And primary in this is loneliness, which I'll talk about today. We recruited a cohort of adults between April and May 2020. So again, this was the time when shelter-in-place orders and social distancing recommendations were in place across most of the country. We recruited people who were at least 55 years old and lived in the US, including Puerto Rico, and who could complete our online questionnaires in either English or Spanish. Ultimately, we recruited just under 7,000 people across all 50 US states, the District of Columbia, and Puerto Rico. What I'm going to show today is an overview of some data from the first 6 months of the pandemic. This is April and May through October, November 2020. And after showing you some, hard data trends, I actually wanted to share some direct open-ended responses from our study participants about their experiences and ways of coping with loneliness. So the COVID-19 coping study is unique in that, in addition to collecting traditional survey data, we also invited people to share their stories with us through open-ended responses about their experiences, about things they were having a hard time with, about how they were coping. And I think these are really important because they provide a lot of nuance and insight alongside, quantitative numerical trends. And I think they're also very important for humanizing the people behind some of the numbers that I'm going to be showing you. So here's the first of the data trends. I'm going to show you trends in loneliness over time by different sociodemographic and social factors. On this slide, we'll start with age and sex, the most basic. So in these two figures, we have time on the x-axis. So it's the month of interview. So we followed up with people monthly, and our data collection spanned these sort of 2-month periods, which is why you see sort of 2 months, 2 months, 2 months, for a total of 6 months. And then we have the prevalence expressed as a percentage on the y-axis. And please keep in mind as we go through, the numbers that are shown in these figures are weighted to be representative of the demographics of the US general population, age 55 and over, and they account for age, sex, race, and ethnicity going forward. So first of all, we see people in the youngest age group, this is the 55 to 64 group, experiencing the highest prevalence of loneliness, and this is consistent over time. This is consistent with early cross-sectional survey data that came out early in the pandemic, where we actually see this sort of inverse relationship between age and loneliness, where it's actually the oldest age groups are seeming to be the least lonely. This opens questions about resilience and wisdom and life experience and things like that in influencing mental health resilience. And I think that's something that we need to understand more. Interestingly, we actually see a downward trend in loneliness among the oldest age group, the 75 plus, heading into the fall winter months, which is something I want to dig into a little bit more. On the right-hand side of your screen, you'll see a figure showing sex differences in loneliness. And we actually see that women are consistently experiencing higher loneliness than men, hovering around 35% compared to about 25% of men over this first 6 months of the pandemic. And it's quite stable and persistent. Moving on, I'm showing you here in this slide trends by race, ethnicity, and relationship status. And let's look first at race, ethnicity. And again, this accounts for age and sex differences across racial and ethnic groups. Early in the pandemic, if you look at April and May, we didn't actually see, notable racial disparities in the experience of loneliness, but this really changed over time. And we actually see that non-Hispanic Black older adults start to increase in their prevalence of loneliness, especially going into the fall winter months. We see about 45% of older non-Hispanic Black adults experiencing loneliness, whereas we actually saw declines on average in loneliness among those who are Hispanic, Latinx, other race, ethnicity, and non-Hispanic white. So these emerging racial and ethnic disparities in loneliness as the pandemic went on, I think are something we need to understand a little bit more. On the right-hand side of the slide, you'll see relationship status, and this might not come as a surprise to anyone. I think this is really important. So people who were married or otherwise in a relationship experience the lowest levels of loneliness, hovering around 20%, whereas people who are single for any reason experienced really high prevalence of loneliness, hovering between 40 and 50%. And employment status. I really want to show employment status here because, as we all know, there has been a really deep economic recession that went along with the pandemic. And I think thinking about workers age 55 and over who are either in the labor force and approaching retirement age or working beyond retirement age are an incredibly important demographic when thinking about maintaining economic well-being and labor force participation. So on the left-hand side, I show data according to pre-COVID-19 employment status. So we asked people what their employment status was as we entered the pandemic. We actually see that individuals who are unemployed going into the pandemic consistently had higher levels of loneliness than those who are either employed or retired. And again, this accounts for age, sex, and racial ethnic differences between groups. So we're really seeing here that the most economically vulnerable subset of older adults are also experiencing the highest loneliness. We then asked people how the pandemic affected their employment. So this would be a subset of people who were engaged in the labor force prior to the pandemic. And we see quite a big difference here. The gray line on the top indicates the prevalence of loneliness among people whose work was affected in any way by the pandemic. And this included losing a job, being furloughed, having reduced pay or hours, or transitioning to work from home. And this was a really high percentage of workers. And then loneliness was much lower among those whose employment was not affected. So I think this is a really important take-home slide here because, as individuals who are, either approaching retirement age or working beyond retirement age are potentially losing their job, losing income, having their economic status compromised, this can potentially lead to adverse mental health effects, including loneliness. We have a whole other report that's come out looking at employment transitions and mental health among the older population. And we see these trends not only for loneliness, but also for things like depression and anxiety. And finally, I wanted to show living situation. And again, this might also not come as a surprise and is really similar to what we see with relationship status. On the left-hand side, we see that adults 55 and over who lived alone had very high prevalence of loneliness, approaching 50%. And it was lower among people who did not live alone, regardless of who their household members were. And this was remarkably stable over time. Similarly, we saw high prevalence of loneliness among those who were living in senior living, whether that was independent or assisted living or nursing homes. It fluctuates a little bit over time, but we do see consistently higher loneliness among this population subgroup, ranging anywhere between 45 and 60% over the first 6 months of the pandemic. So I think what we see in these across the board in all of these slides that I've just shown you is that loneliness is an extremely persistent situation that people experienced over time. In most cases, it's not like it got better as people sort of adapted and got used to living in the pandemic. We saw persistently high levels of loneliness over these 6 months in the early pandemic period. And I finally wanted to round out with some of our direct responses from our participants. I think that these are just a few snapshots. There's a very, very large volume of these open-ended quotes that I could share. I'm just showing a few here. We do have other reports that really get into these in a lot of depth, but I think they kind of illustrate how these feelings of loneliness are felt very deeply and very intensely, with one respondent saying that they felt loneliness, they need physical contact, wondered if they would ever find love again. I think it's been very challenging for people in various types of relationships or non-relationships during the pandemic with the need for physical isolation. Another respondent expressed being afraid that we're going to get used to being alone by ourselves, that we won't reconnect the way we need to when we are able to safely go back to being in person. And that was actually something that was echoed by a lot of people in the study, this kind of worry or fear about what will they be able to adapt once we're back to being in person. On the flip side, I wanted to show some positive aspects and constructive aspects about how people are coping with loneliness, because we did see a lot of different themes of resilience and coping come through in our data. And I think these are really relevant when thinking about solutions. For example, one of our female respondents reported, trying to go to bed early, getting outside, practicing self-compassion, creative pursuits, reaching out to people as they lived alone. And other respondents gave similar answers with respect to coping with loneliness. So across the board here, we see, some participants are learning to be comfortable with having alone time. So getting used to it and sort of adapting mentally to the idea that they are going to be alone. Doing things like getting outside, praying, checking in with people daily, phoning people, sending notes and cards to people, doing exercise. I chose these quotes because they were really kind of key examples of commonly stated themes with respect to resilience and coping. So in summary, as the graphs that I showed you indicate, loneliness was common and it was incredibly persistent over the first 6 months of the pandemic. And we saw really large social disparities in the experience of loneliness. So within this 55 plus age group, we see that younger adults, women, those who are single or living alone, non-Hispanic Black adults, and those whose work was affected by COVID-19 were the loneliest during this time period. This potentially indicates some of the key population subgroups in the older age range who we may want to target to reduce feelings of loneliness and improve mental health and well-being as we hopefully exit the pandemic. And we also heard about a lot of constructive coping strategies, things like mindfulness, getting outside, engaging in hobbies, safe forms of socialization. I think our next panelist is going to talk about some of these, which is really great. But I'll also say that many participants expressed worries and fears about going back to normal. And I think that's something that's going to be really important in public health and governmental communication with folks as vaccination rates increase, as reopening happens, about how we can safely get back in person while minimizing virus transmission. And before I end, I just wanted to direct people to our website. If you want any more information, the URL is here. All of our questionnaires are available there. We do monthly newsletters with our study participants. Those are all available on our website. We have several media interviews and podcasts, as well as published results. Or you can directly email me. My email address is here, or Dr. Jessica Finley, who is the study co-principal investigator. And finally, I just want to thank our wonderful team. This is a product of not just me, but a very large effort. We've got a really, really amazing group of research associates and students who have helped with the study design, the data collection, and data analysis. So I just want to acknowledge their extremely hard work and finally acknowledge the study participants for sharing their stories with us and for sharing their time. And that's all I've got. I look forward to answering questions. And I think now I will turn it over to Jason Maciejewski.
Jason, you're on mute. If you can just unmute yourself, please.
There we go. Thanks, Lindsay. It was a lot of really great information. Really interesting data point on that 75 and over population as well. My name is Jason Maciejewski. I'm the Chief Advocacy and Planning Officer at the Senior Alliance, which is the area agency on aging that covers Southern and Western Wayne County. We have about 1 million residents and serve about 200,000 or so older adults, which we define as people age 60 and over. We are one of 16 area agencies on aging in the state of Michigan and about one of 622 across the country. Everybody lives in an area agency on aging, and you could think of it like a district or a legislative district or something like that. We're commonly referred to as one of the best kept secrets around, because people typically don't find us until they are searching for resources for older adults. We, as a state association, have an organization called the Area Agencies on Aging Association of Michigan. And in 2019, that organization commissioned a survey with Mitchell Communications in the state of Michigan, where we surveyed 600 participants across the state. And one of the things that we asked about was isolation. And we found back then that about 500,000 people across the state, roughly about a third of them have some form of lack of social contact. 1 in 5 say they don't even have enough contact with their friends or neighbors or relatives back in 2019 pre-pandemic. We view that social isolation that is occurring in our community as having direct effects on other parts of people's lives. And you can see by the red lines here on the chart, people who are experiencing loneliness or isolation have a much higher rate in our survey of other challenges in situations in their life than people who don't feel that loneliness. So it's that connection between loneliness and healthcare aspects that people are experiencing. I'm sorry. Got my slide mixed up there. So we at the Area Agency on Aging have a variety of resources to address social isolation, things that we've done for decades in some cases to try and address this in our community. Probably the one that people are most familiar with is the Congregate Meal Program or Home Delivered Meal Program, which is commonly known as Meals on Wheels. This is a program that is designed specifically for homebound older adults and is a way to combat isolation. We have a Friendly Reassurance or Friendly Caller program that many area agencies on aging operate or fund. Ours is a peer-to-peer program. So we have older adults calling older adults, typically anywhere from 1 to 5 days a week to connect by telephone. And that has grown during the pandemic, nearly doubled in size at our area agency on aging. Health and wellness classes are another way that we try and engage folks and get them into the community. These evidence-based programs can include diabetes education or fall prevention. So we do try and get people out and participating in these classes. Some area agencies on aging offer peer counseling through an organization called RSVP. There are volunteering program opportunities that we try and link people to. There are programs called peer programs for grandparents to connect with other grandparents as well. There are communication and monitoring technologies that many area agencies on aging are involved with, sometimes in connection with healthcare entities as well, that allow caregivers to do some of that monitoring of older adults. And we also view transportation services as a way to combat social isolation, getting people to doctor's appointments that they may not have the ability to get to, getting them to other social situations that they may not have the ability to get to because of a lack of mobility. And finally, the traditional senior centers that exist in most communities are ways for people to congregate and gather and be together as well. One thing that we have been doing during the pandemic at the Senior Alliance is we have become involved in the distribution of companion pets. You may have seen, if you live in the Detroit area, a story on Channel 7 last week about our agency. We have been providing these robotic pets, which you can see are they're like stuffed animals, but they have a robotic component to them where they move and they bark and can communicate. We've been working with long-term care facilities and people in some of our programs, including the My Choice Waiver and Care Management programs, specifically people with dementia, to distribute these. And we've had quite surprising success in terms of the reaction that we've been getting to the companion pet program. So much so that other area agencies on aging are contacting us about it. I think we got a call from Arizona yesterday. Somebody came across the news story to find out about the program. And quite simply, these pets cost somewhere in the neighborhood of $100 a piece. But in placing them with folks, it's a help to the caregivers. As this caregiver on the right side of the screen there was quite ecstatic about the difference that it's made in the life of the person that she is a caregiver for. It is something that we're really working on expanding now into the several hundred companion pets being distributed in our service area. So it's things like this that as we move into the future and get into this hopefully later period of the pandemic, we begin to think about the interconnectedness of people, how to re-engage people. And for us, one of the major issues coming out of this is broadband access and making sure people and older adults have that ability to connect with internet, understand how to do it, have the tools to do it, to maintain that connection going forward. And there are a number of things that we are doing to try and support caregivers, hopefully doing things like increasing funding for the Meals on Wheels program, increasing funding for some of these Older Americans Act funded programs, that we can do coming out of the pandemic to address not only issues of isolation, but issues of behavioral health that we anticipate seeing amongst the older adult population. So I'll unshare my screen.
Okay, thank you. Thank you to all of the panelists. I appreciate it. I want to take this opportunity before we move into the question and answer, because I see that he has joined us. The University of Michigan, at the end of last year, our Vice President for Government Relations, Cynthia Wilbanks, retired, and we had the extraordinary opportunity and are blessed to have former city councilman, former state representative, and most recently the state of Michigan's budget director, now serving as our vice president for government relations, who will be leading the charge and kind of helping us develop the kind of topic areas for Wolverine Caucus and our engagement with the state. So with that said, Chris, welcome.
Thank you. Appreciate being here, and I won't take any more time and back to the discussion, but really it's a pleasure being here, and I look forward to working with everybody. Thank you.
Thank you, Chris. Thank you. So again, thank you to our panelists. Appreciate that. If anyone has any additional, I see a few questions in the Q&A. If anyone has any additional questions, feel free to put those in the Q&A. If you want to direct them specifically to any of the panelists, that would be great. I think first, Lindsay, it seems as if, and even Jason, it seems as if a couple of questions have popped up related to the definition of loneliness. I would say specifically, Dana asks, is there a definition that you use for loneliness, and why did you focus on loneliness? And is that a factor in health? And I guess I'm going to add a little bit to that based on a question that we received earlier, that with what is the definition of loneliness, and then what is our next iteration after loneliness, after we start to see, I use the layman's term of anxiety, knowing that I am not a PhD in psychiatry, but what kind of do you think is the next iteration of where we go? So Jason and Lindsay.
Yeah, if you don't mind, Jason, can I start with the answer to that one? That's a really great question, and we should talk about that. And before getting into the specific, survey questions that we use to ask about loneliness, I wanted to make a distinction between social isolation and loneliness. And I think that we often kind of think of the two as being the same thing. But typically, in the academic world, when we study social isolation and social isolation and loneliness in relation to health to understand their effects on health, we consider social isolation to be an objective state where you have few actual, physical or virtual social contacts. So it's really like you are truly isolated. You can measure and count this person, does not have measurable social contacts, whether they are friends, family, neighbors, things like that. So you can have, a very large and diverse and tight-knit social network, or you can have very, very few social contacts. So it's kind of this graded phenomenon that is a measurable number and kind of closeness of social contacts. What we're talking about today is loneliness, which is more of this psychological feeling or the emotional experience of being alone. And research studies have shown that people can be socially isolated, so they can have, they can live alone, they can have not many friends or family members, but not feel lonely. And sometimes people enjoy and seek out that kind of solitude. There's different personality types, different life situations, and that can be fine. But there, on the flip side, can also occur where people can have, a big tight family. They can have, other household members and friends, but still experience that feeling of loneliness or being alone. And that's this sort of feeling or emotional experience of loneliness is very, very closely tied to mental health. We actually consider loneliness to be a symptom of depression. And this is where it all gets a little bit complicated, right? Not everyone who is lonely is clinically depressed. And not everyone who experiences depression always experiences loneliness as a part of that. But I do want to express that loneliness and mental health in the form of depression they often do go hand in hand, but not all of the time. And what we're talking about today is this emotional or psychological experience of loneliness. And we actually think that both of loneliness and isolation have health effects, but they might be slightly different. And it's really important to distinguish whether we are talking about actual isolation versus this psychological or emotional experience of loneliness, because that tells us what we should be targeting with our interventions. Should we be targeting a person's, mental health state and emotional state versus targeting their actual, like, measurable experience of isolation defined by their social context? So that's just some kind of starting definitions for where we are here. In our study, in the COVID-19 coping study, we used a research scale called the UCLA 3-item loneliness scale. And that scale asks 3 questions about loneliness. And in the survey, we say, this question is about how you feel about different aspects of your life. Please indicate how often you felt this way in the past week. And then we ask 3 questions. So 1, how often did you feel you lacked companionship? How often did you feel left out? And how often did you feel isolated from others? And people can tell us either hardly ever, some of the time, or often. And these are similar to the 3 measures of loneliness that you saw for the National Poll on Healthy Aging. So the measures are actually very comparable between the 2 studies, which is kind of nice. And then with respect to past studies indicating that loneliness is an important factor in health, there's a large volume of scientific evidence that I would say is good quality that links loneliness with a range of adverse health outcomes. And I can share some papers in the chat maybe after this. Experience of high loneliness has been consistently linked with cardiovascular disease outcomes, so things like heart attack, stroke, other cardiovascular risk factors. It's been linked with increased rates of cognitive decline and dementia in older adults. It's been linked with increased risk of all-cause mortality, and the specific research instrument that was used in the COVID-19 coping study and National Poll on Healthy Aging has been people who score highly on that scale have an increased risk of all-cause mortality independently of a lot of other factors. And I think that's why Preeti said that, the experience of loneliness has been compared to smoking with respect to the strength of its association with health outcomes. So we're very concerned about loneliness as the sort of emotional or psychological experience of being alone and how it affects health.
Jason?
I would add that as an area agency on aging, our programs are primarily focused on social isolation. And Lindsay did a great job of talking about the difference between that and loneliness. We really look for factors that lead people to be isolated in their homes, whether that's a lack of mobility, whether that is a lack of caregivers, a lack of family members. Those are some of the major factors for us when we encounter people that are enrolling in our programs and offering them a variety of resources to address those issues. When we begin to do that and enroll people in Meals on Wheels, for example, we begin to then identify the loneliness that is going on in their life, and then are able to offer other resources that might begin to address those kinds of things, whether it's the Friendly Reassurance Program in addition to the Meals on Wheels. So for us on the area agency on aging side, it's really a focus on that identification of isolation in an individual, and how we can address that with some of the resources that we have.
Okay, I'm going to add on to Preeti. Preeti, adding on to that, from your perspective for the future polls on healthy aging and kind of using those definitions and identifying some of those health factors and health risks, I think, and also just how we as a nation, a world, I guess, but specifically the state of Michigan moves on from a policy perspective. Where do you see kind of healthy aging polling in the next year, as far as how we're going to kind of identify and utilize the polling to help make more targeted policy decisions and health outcomes?
Yeah, thanks, Rebecca, for that question, and thanks, Lindsay and Jason, for that just masterful discussion of the difference between social isolation and loneliness and the importance of it. And again, I to bring it back to college students who actually are surrounded by people, but are often very, very lonely. So in terms of where we're going forward, the pandemic, as everyone knows, it's affected every aspect of our life. And, we think a lot about, the K through 12 space. We think about older adults. We think about people who may have job loss and loss of health insurance. So, I think where we're headed is thinking about, some of those lasting changes, and where we are getting ready to think about, future polls, and, what have people, like, what's going to be the next step, and I will just say, I'm very hopeful that we are going to be in the next phase soon. But this idea that we're going to go back to normal, it won't be like a light switch. It's going to be like a dial where we're going to slowly, and that dial might go back and forth. But what if people learned, and that idea of resilience too, the idea of grief and loss that so much of us have experienced, not just actual loss and death, but just loss of so many things that we had planned for. And again, different for younger people, different for older people. And I feel like those are going to be some of the things that we're not going to capture in a traditional medical model, but are going to really, this whole generation, I think about my own kids. I have a student who's at Michigan, and how all of this is going to affect his entire career and the kind of questions he's going to ask as an operations engineer.
Okay, thank you. Jason, we have quite a few questions for the AAAs, and I'll try to put them all succinctly together, and hopefully we get them all answered. But basically, Dana kind of sums it up with, what were some of the programming at the AAAs that was stopped or had to be kind of reassessed and re-implemented? And then as far as, is there kind of a clearinghouse website or location for individuals to go to for the list of resources that are being offered to seniors, as example of the robotic dog or grandparents or some of the things that you kind of talked about?
Right. So I'll start with that list of services that's been impacted. Basically, everything we do has been impacted in some way or another, because our workforce is now 100% remote, and has been that way for almost a year now. In terms of programs that have stopped, probably the most noticeable one is our transportation program. We had been operating a door-to-door transportation program, getting people to doctor's appointments and pharmacies and specialist appointments. We were working with probably about 15 to 20 people a day in our service area with that program, and it completely stopped. And it stopped because our vehicles could not be, we don't have the bigger 15 passenger vehicles. We have minivans and Priuses, and for door-to-door service, and we could not retrofit them for what we needed to do for COVID. So that program stopped and has not resumed. And many transportation programs in communities have gone through that same process. That's probably the most notable. We are no longer able to go into people's homes, which we have always done, to do assessments and care planning work. All that is being done telephonically, and our social workers and our nurses freely acknowledge that's not the best way to set up a care plan for somebody. They're used to being in that home environment and seeing how people function in their living space, and that's hindered potentially some of the services that might be available. Most of our other programs are operating telephonically and typically as normal. Probably the biggest difference that people might see is Meals on Wheels. We no longer have a congregate meal program. We can't have dozens of people getting together at a senior center to eat lunch anymore. And our Meals on Wheels programs, for the most part, are now multi-pack delivery or shipments. So we had been operating a 5-day-a-week hot meal delivery, and we are now operating a 1-day-a-week 5-pack frozen delivery in our service area. I know in Washtenaw County, for example, in the Ypsilanti area, they're doing a 3-day-a-week hot meal delivery. And that may be the biggest impact, is that is really affecting our ability to interact with people who are really isolated on those programs. And so my in-laws are participants on the Ypsilanti Meals on Wheels program, and they started during the pandemic. And I can tell you, by being able to get onto that program, it's made an incredible difference in their life, because they had a pretty good degree of isolation in their home. And so I've seen firsthand the difference that can make for somebody, even during the pandemic. The second part of your question after the service list.
Basically, I think, and maybe I can ask all three panelists, is there a clearinghouse or a great website that kind of provides, I think of myself and listening, and Lindsay, your last slide with or the second to last slide with, hearing those direct quotes about what people are feeling, I think really brings it home for the average citizen, in that, what can we do? Or as we're looking for resources for the elderly in our lives, whether it's neighbors or family members, is there, and Jason, I also agree with you that the Area Agency on Aging is that entity that everyone doesn't think about until they need to. So just where are some nice or quality websites or information sites for gathering that information for people?
So the Area Agencies on Aging, that is our role. We are there to be the resource for aging issues in the community. Maybe the easiest way to get access and figure out which region you live in is to go to the Aging and Adult Services Agency website, where you can see all 16 area agencies on aging in the state. If you simply search Area Agency on Aging Okemos, the office of the Tri-County Area Agency on Aging is going to pop up for you. But I always direct everybody to go to their Area Agency on Aging as a starting point, because we can then warm hand off and refer people to the VA or to whatever organization might also provide services and supports for people.
Okay. So my question, the next question brings together a couple of what we're talking about, but many of our participants today, Lindsay and Preeti and Jason, are people that work at DHHS in senior services. And how do we kind of use this data, use our personal experiences to make our next policy decisions? And do any of you have, Lindsay, you kind of touched on a few recommendations, but do we have any recommendations for, even if it's all the way down to a public service announcements or recommendations on how to connect with our neighbors? And then even a more critical types of resources. So do any of you have recommendations on utilizing this information?
Yeah, I think I can speak to a little bit of this. I'd be curious to hear what Jason and Preeti think. I think one of the themes that's coming through, and I think this is a strength of having these open-ended kind of qualitative data, because they give us a little bit more nuance on how people are really doing. We really saw strong themes of fears and anxieties about going back to normal, or being able to cope with going back to normal and being in person and things like that. And so I think as we, I'm an optimist, as we kind of like turn up that dial that Preeti said and start to reopen and start to relax restrictions, as as the vaccination distribution goes up and things like that, I think that really clear and consistent communication from the CDC and local public health agencies, local and state governments, is going to be really important, so people are clear on what is the actual kind of safe level of interaction with people, and to ease anxieties about it. And I think we saw early in the pandemic there was a lot of conflicting and confusing public health messaging, and I think we want to avoid that this time around as we turn that dial towards reopening when it is safe to do so, and just being aware that at least in the older range of the population, I'm sure this is probably also true for younger people, we just didn't survey younger population groups, that there are some fears, anxieties, and concerns about it that should be addressed with, I think, clear and consistent messaging from the relevant agencies.
I would just echo that, when you've been told to stay home and not leave, and unless it's absolutely essential, it's hard to go back to something that feels more typical. And, I think having data, having consistency and clear messaging, and, it's hard because there's not a clear answer. It's hard to give blanket guidance because there's a portion of people who life is normal, a portion who are afraid, and then the rest of us who are trying to just keep moving.
Jason?
The older adult population that we deal with is incredibly afraid of what is out there right now. And we put a lot of effort into trying to be very consistent in terms of the information that we are putting out and will be putting out. Right now we're putting a lot of effort into trying to make people aware of the vaccine safety and being very consistent and deliberate about how people can access the vaccine. So we rely a lot on information from our county health department and make sure that the messages that we are giving to the hundreds of people that call us every day is the same information that's being given out by the health department, and that consistency is really important. And when dealing with a population that is really on edge at this particular moment.
Right. Okay. I think there's a couple of different questions, but I think in the most part we've answered them. I'm going through. I think we have. I guess I want to kind of end a little bit on a personal note of talking to each of the panelists about. I assume we all are dealing with, like Lindsay said, this loneliness factor, no matter whether we've been on Zoom since 7:30 until 7:30 at night. There's still this bizarre world of looking through a screen at people while your basement or your kids are running around in the background. I guess from a personal standpoint, what are each of you kind of dealing with, and how are each of you addressing it in your personal lives, and either that or making recommendations to your neighbors, friends, and family? So I'll start with Lindsay.
Sure. So perhaps my situation is a little bit unique because my family is spread across different countries. I'm actually from Canada, from British Columbia. So all my family, all of my immediate family are in Canada. So it's been interesting to compare the sort of response and experience there. So I'm on Zoom with them anyway. So that for me personally hasn't changed. It's been hard I haven't seen my family in over a year. That's been hard. But personally, my husband and I have been following, public health recommendations. For me, the biggest thing is just getting outside and, exercising, being in nature. We're very fortunate to have been able to do that. I have personally been, doing kind of virtual Zoom calls or phone calls with friends. Early in the pandemic, I found myself phoning friends and checking in on them more often than I would. So yeah, it's really like technology's played a big role for me, but I do know that not everyone has that access. And I think that's something that we do need to prioritize, during and beyond the pandemic.
Preeti?
Yeah, sure. This has been such a bizarre time. And, for me, as an infectious disease doctor, it's been a very busy time. And professionally, in some ways, it doesn't feel that different. I mean, it's very different, but I still go to work. I still have interaction with people, although I haven't been in the office in several days. So I still get to maybe have some of that contact. And as far as my family, we're native Michiganders. My husband and I are both from the area. And it occurred to me I haven't seen my parents in a couple months, but we're all vaccinated now. And I really keep my life safe day to day so that I am able to see them safely. I obviously have more contact at work, but I feel very good about that. It's complicated because I also have college age kids and I want them to see their grandparents. And what I really think about is what can be done safely, not recklessly, but safely, and getting outside and connecting and, maybe just checking in when I'm driving from point A to point B. And Michigan is, I probably wouldn't have been out in February a year ago, like if it was a different year, but I've been out every single day and rain or shine. And again, not everyone has that ability, and particularly older adults, it may not be safe, but put a chair in your garage if you can. And like, I think what I've focused on with, and even as I'm sitting here, I've gotten multiple texts from friends and colleagues who are like, hey, can I go? And I want to go see my mom. And what I talk about is you're not going to get to zero risk. And I think this is the case for us for the foreseeable future. We're not going to get to a point where COVID is just zero risk, but is the risk acceptable? And there's a competing risk of not seeing your loved ones. And again, I think that there's a way to do it that's thoughtful and safe, but it's, and frankly, the people reaching out to me are actually like doing everything right. And so my discussion every day is like, what can we do? How can we do it safely? It's not zero risk, but not doing it is also risky.
Right. Jason, I know one of the things I did not include on this webinar in your introduction is your role on the county commission, and you also experience it from that perspective, but from a personal perspective, and also from a county services and public health perspective, what are your recommendations? What are you experiencing as someone who is a elected official with constituents and that type of thing?
Yeah, it's been really interesting, and I identified a lot with what Lindsay and Preeti had to say in terms of what's going on personally. For me, I had a grandmother pass away last April in the middle of COVID, and she's 96 years old. And she had been admitted to a nursing home for the first time right when COVID started. And she quickly declined. And as we all know, you couldn't go visit. So that was something that was really difficult for my family to deal with. My in-laws, which I mentioned earlier, we're beginning to deal with dementia that has come on during COVID. And for my wife and I becoming caregivers during the pandemic, and how we can do everything we can to be safe. And we go over there and we double mask when we visit and try and help them out. But it's a lot of it is about doing everything in your life to keep yourself safe, to keep everybody else safe, right? So in terms of being an elected official and dealing with the resources in Washtenaw County, it's been really most intense in the last month with the vaccine rollout. And like I was saying, with the Area Agency on Aging, trying to be consistent with messaging, I think that's been one of the biggest frustrations as an elected official is how wide open the pool of eligible people for the vaccine has been with such a limited supply of vaccine. And getting calls from older adults saying, why, I'm 77 years old, why haven't I gotten it yet? Why haven't I gotten it yet? Or, my mother is senior, why hasn't she gotten it yet? Or school board members saying, why can't we vaccinate all our teachers this weekend? and trying to go through that process, but really being, again, referring back to county health and the public health officer and being consistent with the message. And sometimes when overall on the big picture, things maybe not be so clear and transparent everywhere, but I try and be very consistent with people locally in my area. So really talking from that county health department perspective is important, I think.
Okay, great. Well, I cannot say enough of how critical we think this conversation is from a government relations, but more importantly, from a public engagement standpoint. Our President Schlissel has always made it a priority in his administration that public engagement and working with our public policy partners to provide critical information and informed information helps with informing our public policy decisions more effectively. So thank you so much to all of our panelists. I want to also thank all of our participants for joining us today. If you're interested in sharing this presentation, it should be posted by the end of today or tomorrow on U of M's public engagement site. I have included that in the chat, but it's basically just publicengagement.umich.edu. Please join us for our March Wolverine Caucus as we will begin to discuss maternal and children's health and the collaboration between the state of Michigan and U of M's 0 to 5 program. So on behalf of our Vice President for Government Relations, Chris Kolb, the University of Michigan Alumni Association, I just want to thank everyone for joining us and have a great weekend. Thank you. Bye all.